All right, so first of all, just to start with a disclaimer, I'm a member of the Institutional Review Board of the All of Us Research Program in the United States. Therefore, everything I say is my personal capacity, my fault. Every wrong statement will be from me. Don't blame it on the system. So just a quick introduction. There's a growing national and international investment in precision medicine research, and it has kind of the significant features of trying to replace the idea of one size fits all to a much more tailored, individually tailored, holistic approach, which takes into account genomics, biological factors, environmental factors, lifestyle choices. I'm sure you know that, but I just kind of wanted to bring it all to the same page. It also has a unique feature of focusing more on complex and chronic health conditions, which means that these are the conditions that are really overburdening the society and populations, and so there's much more investment in those conditions. In the United States, at least, precision medicine research has come up with a lot of discussion about empowerment, where there's an idea that, hey, we're going to give back results to participants. They're going to be able to take that information, act on it, reduce their genomic risks, and therefore we're going to empower them to act on those findings. So it's a very big conversation there. And then overall, the idea is that, at least in the United States, we really want to curtail some of the health disparities that we have that have been disproportionately affecting marginalized racial and ethnic communities. And so it really has become this national priority in the US setting. In 2015, President Obama announced the establishment of the Precision Medicine Initiative, which is now called the All of Us Research Program, with the goal of revolutionizing the healthcare system and how we think about it. They are hoping to enroll 1 million individuals into that program, making it the largest precision medicine research program in the world, with significant budgetary allocations. And if that wasn't enough, then in 2006, it kind of was followed by the National Cancer Moonshot Initiative, another huge initiative to focus on cancer, a huge genomic focus, as well as a $1 billion jumpstart. So obviously a lot of investment. So what I want to do is to, first of all, that was kind of just the beginning of the reorientation, but to kind of think about the questions of diversity and trust in precision medicine research. And then I want us to focus on people with disabilities, which is really my community, the population that I've been working with for over 2 decades. Share with you some of our research findings with this community, very heterogeneous community, as we'll see. Then refocus again on distrust and ableism, what it means, and then moving to how that might impact precision medicine research initiatives more broadly, focusing on questions of, again, representation and ableism, data sharing, and what did I want to say? And the identification questions, which I think we haven't had enough thought about that. So with that in mind, let's just kind of start with broader, again, a little bit discussion about why do we need diversity in precision medicine research. And there are several reasons that we often hear in the context of research and why it would be good for it to be diverse. One is really trying to better understand the health needs of populations. We want to create better tools. We want to have more tailored medications, effective drugs, better diagnoses. All of that requires that we have diversity in the cohorts that are being studied. Also, the more diverse the population we have in research, including precision medicine research, the findings will be more generalizable, which means they'll be applicable for a greater number of people. Another reason for diversity is the cost. The less diverse we have, the less representation we have, it means that we reduce life expectancy, we're increasing these experiences of disableism, along with impact on the workforce. And therefore, again, it costs much more to do precision medicine research on small populations compared to what we can achieve if we have larger representation. As I mentioned previously, again, the population health and health equity are really critical for precision medicine research, and that's a major goal. But without diversity, we're not going to be able to move those things together and really change health disparities and promote health equity. There's a question of trust. People who are underrepresented in research, including precision medicine research, are always keep at the back of their brain is like, well, is this really applicable for me? I'm getting medication from my doctor. Does that medication work for me? Would it work for me? What sort of harms may I have? Again, it raises a lot of questions of trust and distrust. So again, greater diversity and representation might have a positive impact in increasing trust. And then finally, biomedical citizenship. And I'm not coming from the perspective of, hey, we all have to participate in research. I think it's a personal choice. But clearly, if we're thinking about everyone as equal partners, as being included in all aspects of life as equal members of society, then biomedical research, including precision medicine research, is one of these areas. And again, just the inclusion, we know from research with underserved communities, gives the sense of we're being invited as part of the community, we're being treated as equal partners. So when we think about diversity in the United States, it's also a requirement. The National Institutes of Health specifically requires gender, racial, and ethnic diversity, as well as age diversity in studies, with very clear requirements that exclusion can only be done, cannot be done without scientific rationales and regardless of cost. Cost is not a good enough reason to say we're not recruiting certain populations. But in reality, we also know that we've kind of failed with diversity in research. The report on the left, which is from the National Academies of Engineering, Sciences, and Medicine, focused on diversity in health research in the United States, finding that, and I quote here, that there's been the progress has been uneven and largely stalled regarding participation of racial and ethnic populations in medical research in the United States. So that's been a big issue. But also when we look at genomics, that's the article on the right, and that's kind of been a really seminal piece, I think, in the context of genomics and precision medicine research. There have been findings from 2009 that about 96% of the existing genomic cohorts have been of white European ancestry populations. In the time that this article was published in 2016, there's been some progress, but it's still indicated that more than 80% of existing cohorts comprise white European ancestry participants. Now, I'll say that there have been some changes. The All of Us research program, which is again the national effort, has done a great effort to increase diversity, and they have more than 50% from their cohort from marginalized racial and ethnic communities. But that is still not the case for many other local and smaller cohorts. And there are, I think, also some issues here, and we'll see it in a second. So when thinking about why do we not have diversity in genomic and precision medicine research, one key aspect that has been brought up again and again and again is the issue of trust. And there's growing literature indicating that marginalized racial and ethnic communities do not have trust in the biomedical system, in the healthcare system, and therefore in precision medicine research, and therefore they do not enroll into those studies. And so in an effort to address this distrust, there's been tremendous efforts to create studies that are mobilized by community engagement, with community engagement really being seen as the way forward, something that is perceived as a bidirectional process, something that builds on equal partnership between researchers and community members, helping researchers to identify what are the health needs and priorities of specific communities, and kind of to create an increasing dialogue between researchers and members of the communities, also in order for researchers to be able to self-reflect on their own biases and to increase their, what we call cultural humility, the ability to think beyond the one lens that they've been educated into, to try to understand health perspectives from different communities, to really try to better engage with communities that have been historically underrepresented in research. As I'm hoping to show, and this is all kind of great work, but I hope to show that we have to start thinking about expanding the question of diversity beyond gender, racial, and ethnic diversity, to really think about diversities within those communities. And in particular, the community that I'm working with and I'm very interested in is the people with disabilities. So that brings me to kind of the second part of my study, of my talk today, which is the community of people with disabilities. So I want us to give us just a brief snapshot of the community itself. I think there's been a lot of discussion about it, but I think we all know people with disabilities. There's no single person who doesn't, but I do want us to have a picture of the population. And obviously it's a very large and heterogeneous population. There are different needs, different conditions. But in the United States, it accounts for 20% of children and 26% of adult population, and that's before the pandemic. So if you take into account long COVID folks, that's a very, very large population. Disability is also a universal phenomenon. It cuts across age, race, ethnicity, gender, socioeconomic, like every possible demographic that we can think of, it exists. With one thing is that due to structural discrimination and biases, there's, at least in the United States, disproportionately high prevalence of people with disabilities in marginalized gender, racial, and ethnic communities. And it's by far more than their relative prevalence in the population. People with disabilities also have significant health disparities and low social determinants of health. And our minds are usually thinking about people with disabilities as necessarily having medical conditions, but having a disability does not mean having a health condition. You can be blind, but be very much healthy. And yet, again, because of trouble getting access to care, getting tailored medications and so forth, there's significant challenges in actually achieving health. And in the United States, it's definitely, there's low social determinants of health across the population in terms of access to medication, in terms of access to information about health, in terms of education, in terms of access to the internet, pretty much anything that comprises social determinants of health. So all of that is to say that if we're thinking about precision medicine research as one way to improve healthcare for health outcomes for populations, for the general population, and certainly to curtail health disparities, we need to include people with disabilities in those initiatives to really try to better figure out what would be helpful for that population. Now, of course, there's been a long history of problems with genetic research that has been controversial within this community. Genetic research is central to a very medical approach to disability that has traditionally focused on impairment, conceptualizing it as the abnormal, thinking about disability as an individual trait, something that needs to be fixed within that individual. We're moving sometimes into population levels when we're thinking about prenatal screening, eugenics, but ultimately disabilities are often grounded in individuals. This is how it's being perceived. And historically, they've been considered as object almost, and people who lack capacities to make their own decisions. And that comes with the whole history, right, of abuse, discrimination, eugenic practices. This is a picture from Munich, which really kind of showed how that population was targeted during the Third Reich as well. Now, from a legal perspective, there's definitely been a lot of changes, right? Disability has moved from objects. There's a lot of conversation about interaction between impairments and societal and environmental barriers. There's growing awareness of the need to respect differences, accept people with disabilities as full subjects. In most countries that have signed and ratified the Convention on the Rights of People with Disabilities, we also have very clear positive state's obligation to ensure accommodations, accessibility, and so forth. And there's a strong and increasingly and growing concept of identity among people with disabilities. It started perhaps in the 1970s or so with the deaf community, even before, with the deaf community in the United States, where people who are deaf say, it's not who are deaf, we're actually being deaf. This is who we are. We have our culture, we have our practices, accept us as we are. I will say that there are many other subgroups within the disability community that have identities that are related to that condition, such as Little People of America. There's also the autism and neurodiverse movement that really think about their condition as part of their identities. So the medical approach remained strong despite the fact that we've shifted in the legal discourse about people with disabilities as subjects of human rights, as owners of human rights, and so forth. So the question that I kind of started was, well, so would precision medicine research be different? If we think about precision medicine research in its most hopeful and promising way, we're thinking about it as something that doesn't only focus on the genetics, but actually looks at environment, lifestyle choices. So it really is more attuned to the social relational model of disability. It also, again, aims not only to focus on the impairment itself or the genetics that cause a disability, but actually looks at chronic diseases which are disproportionately impacting this population. When the entire world of precision medicine research kind of emerged, and really there was conversation about it all over the place, there were studies on right and left with all the populations that you can think of, about parents, with parents, with patients, with potential public members, with researchers, you name it. There hasn't been a single study with people with disabilities. So that kind of gave us a pause, and we said, okay, we've got to figure out, what do people with disabilities think? And so this is the emerging, that what we started doing, and that was a disability survey that we've done in 2018. It was across disability, meaning we've invited essentially anyone who self-identifies as a person with disability to take the survey. We provided an explanation about what precision medicine research is. The survey was online. We did national recruitment, and the survey itself was accessible. That was the first time that their views were kind of explored, really trying to figure out how they are and where they are in that context of precision medicine research. And what we found was, first of all, we had a pretty diverse population. You can see we've enrolled almost 1,300 participants in the country. About a third were either blind, deaf, or with mobility, physical disabilities. We had just about 50-50 male, female, but also some populations of others, small ones, but nonetheless, we had some racial diversity, primarily African Americans. 17% of example were African Americans. And we had a pretty nice example of Hispanic population as well, which was just over 30%. In terms of what we found is that, first of all, there was something here that was missing. There was a picture there. But we found that most would participate in precision medicine research if they were asked, 89%, which is a very high rate. Most of them stated that they would be willing to provide biological data, lifestyle information, not so much environmental, social media, and Fitbit information, but the biological information, genomic information, saliva, were all sort of on the with the majority saying that they would provide it. We also found that most would want to get a variety of genetic and other results back from this type of research. And if you can see that my genetic results was actually 78% of our sample, which is quite high. And then sort of if you look into the other medical findings, so we have 68% wanted to get genetic results about a treatable condition, 61% wanted to know genetic results about untreatable condition, and then medical records, health history, and others kind of got 63, 61%. So again, it's fairly high, or at least the majority that wanted to get this type of information. In terms of engagement, which again in precision medicine and research in the US is very strong, we found that they were highly supportive of being partners. They wanted to be equal partners with researchers in those type of research. 84% thought that they should be equal partners. They wanted to be particularly engaged in the design and data collection aspects of research, especially the design, wanting to decide what studies will be made, what are the research questions to be explored, and what focuses they should be. So that was really, again, just trying to have a say as to where the agenda will go. All right, we also found that intersectionality mattered. So far I kind of spoke about it in very general terms of the disability community in general, but we did find differences by disability communities, by race, ethnicity, as well as gender subgroups. And what we found is, for example, with the disability community, is that blind, low vision individuals were far more likely to express interest in all aspects of precision medicine research, from participation to return of results to provision of data, compared to deaf and hard of hearing individuals, as well as other subpopulations such as adults with intellectual disabilities or autistic individuals, for whom there was much more contested relationship with the medical approach, who expressed less interest in participation in data provision and even return of results. Race, ethnicity, we found that overwhelmingly across questions, white participants were far more interested in all aspects of precision medicine research compared to people with disabilities from marginalized racial and ethnic communities. And the gender group was also interesting. If we look into research in the United States about genetic information, genetic testing, and results, we find what we call the genderization of genomics, where women are far more invested in being tested, getting results, informing their family members, having those conversations compared to men. We found, however, the opposite, that women with disabilities were less interested than men with disabilities in being part of precision medicine research and getting results back, especially when it got to genetic results. So obviously there's a big question as to why that might happen. Why do we have those differences? Our study did not offer a lot of option at that time to do that. We did find some things that indicate that, for example, there might be some privacy concerns where non-white and African-American participants were less likely to believe privacy protection is possible. We know that there's a lot of concerns around privacy issues. There were questions of potential disempowerment and structural racism. Again, non-white and African-American population in our study were less likely to see themselves as equal partners compared to white participants. They were more likely to think that precision medicine research will take away from other important health needs that they might have. And in previous studies, there was finding that also African Americans feel that they cannot actually act on the results. So part of the reasons why they don't want to get the results back is because they can't really do anything about them because of all the structures in place. So we thought that might be a possibility as well. And then, of course, there's trust, right? There's been such cases of misuse and abuse of marginalized racial and ethnic communities in the US health research systems that it might be a problem, as well as in the context of women. Women with disabilities have long had such surveillance over their reproduction with presumptions that they're asexual, a lot of misperceptions. And so they might not want to be a part of that system again, that kind of might reinforce the presumption that they are responsible for having children with disabilities, that they are the ones who pass it along, and so forth. So that brings me kind of to the third part of our talk, which is on distrust and ableism. So I wanted to start so what is trust, right? I've been talking about trust and how it impacted the history and how it might impact us today, but we don't actually know what trust is. So the common definition of trust is the willingness of a party to be vulnerable to the actions of another party based on the expectation that the other will perform a particular action important to the trustor, irrespective of the ability to monitor or control the other party. But even if that's kind of the common definition, and I think we all use the words trust and distrust so many times in our daily lives, it's increasingly acknowledged that it is also a highly, highly complex and ambiguous term. For example, when we think about precision medicine research, is it personal, that is the trust that I feel towards another person? Or is it institutional, the trust I feel towards a system or a profession? Is it vertical, that is the trust that I feel because of someone else's intention? Or is it horizontal trust, that is because I feel we have shared characteristics, whether it's language, history, other features that make me more trusting of that particular person? It raises questions about, do we focus on the process or outcome? Are we building trust over a long term and step by step, or do we just measure it at the end? How many people actually enrolled into a study, for example? Other questions are, what societal unit to measure? Do we measure it only on the individual level or also on community level, right? If it's an individual level, it's my personal decision whether to join a study. But if an entire community of blind, low vision individuals doesn't join a study or has significantly less interest in enrollment, that was not our case, but it will be deaf community, for example, do we have to measure it on the community level rather than an individual decision? And then, of course, what components comprise trust? And that's kind of, again, something that researchers have been trying to figure out, some suggestions about questions about harm, but ultimately it feels like it's like the elephant in the room. We know it when we see it, and we know it when we don't have it. But what it actually comprises, it's much more complicated. So in the context of, again, marginalized racial and ethnic communities and the context of precision medicine research, studies have found that there are 4 key areas where distrust might come up. And the research suggests that those key areas are patients-physician relationships, including whether they're being treated with respect and competence in the context of healthcare system, in the context of their interaction with their clinician. It comes up in the context of experiences with healthcare settings more generally. Do they have access to services? How do they have access? Is it too burdensome or not? It comes up in the context of feeling discriminated against. Do they feel that they're being treated as inferior, as undervalued, and so forth? And then there's question of individual and group harm. That is, do they feel that they've been mistreated on the individual basis, exploited in research, them or their communities? And what's also found is, and that's by study by Kraft et al., is the spillover effect, which is all those aspects are likely to extend not only to exist not only in clinical settings, but actually spill over to research settings. So if people do not feel comfortable in any of those four areas, they are also not going to feel comfortable in the context of precision medicine research. But also that it expands beyond the very specific communities who experience any type of discrimination. So say, for example, if we know that African Americans have had previous experiences that fit with any of those bad experiences, any of those four criteria, that these experiences and knowledge of the abuses that they have had in the context of healthcare system also expands to other Hispanic populations, Asian populations, and other marginalized racial and ethnic communities. So it has a huge impact overall. So the question for me was, of course, well, so how does that impact people with disabilities? Again, we don't actually have a lot of information about it, and I'll say that this is actually one of our research now, which we're trying to figure out in greater details. But in this, so that kind of brought me back to, well, let's think about how disability has been discussed in the context of society and the four criteria that we've just discussed so far. And of course, if you look into the social construct of disability, historically, it's always been negative. In the 19th century, people with disabilities were viewed as a disease upon the community. They've been exhibited in circuses and freak shows, which is kind of the picture on the left. In the 19th century, when we moved into the perceptions of the rise of scientific knowledge, we've moved to conceptualize people with disabilities as objects of pathology, treatment, and elimination. Along with, of course, institutionalization of those who are deemed incapable to make decisions. And of course, how those decisions were made is a different story, but of course have been completely biased. And although there have been some changes in the past few decades, and we do have more films, for example, today that show characters with disabilities, for the most part, the depiction of people with disabilities is still pretty negative. Think about the bad guys, the villains in every film, they're always with disabilities. There are other villains, there are other, or they're innocent fools, sometimes they're victims, but it's pretty negative. It doesn't see them as full people. And in fact, the image on the right, which I like showing just because it's a cartoon that was used very widely when Dr. Stephen Hawkins died in 2018, the main thing that indicates here is that he was freed from his wheelchair. Rather than for his really significant scientific achievements, which of course again reflects that negativity. And it comes also to genomics. So in all of that, kind of brought into the structural ableism that we know it today. So structural ableism is a system that places a value on people's bodies and minds based on socially constructed ideas of normalcy, intelligence, excellence, and productivity. This form of systemic oppression leads to people in society determining who is valuable and worthy based on a person's appearance and or their ability to satisfactorily reproduce, excel, and behave. It has been very heavily intertwined with issues of anti-Blackness, racism, eugenics, colonialism, and capitalism, especially in the United States. But it's also multi-leveled and intentionally and unintentionally really occurring at the interpersonal, institutional, and structural levels of society. And it is also, of course, in genomics. If we think about James Watson, who's been obviously the one who kind of came up with the double helix, he's been known for making quite significant racist and sexist comments throughout his life, but he's also been the one who kind of created the idea of ableism here with his statement that seeing the bright side of being handicapped is like praising the virtues of extreme poverty. To be sure, there are many individuals who rise out of its inherently degrading states. Kind of building the agenda for a lot of the genomic research that we have today. So when we're thinking about it in how that kind of reflects into precision medicine research programs and how people with disabilities can engage in them, when we ask participants in our studies, so what are some of the barriers for participation in precision medicine research, we can find that there's a lot of limitations and barriers for their participations. These are just some of them that we found. The no health insurance coverage is 27%, and that might be unique to the United States. But We found, again, quite significant folks who have problems with transportation. It's the majority. 56%, more than half of our participants, have problems with accessibility of facilities and equipment. We have, again, very large populations, 41 or over 40%, who have problems with the cost of transportation, communicating with clinicians and researchers, as well as the idea that information about precision medicine research is not in accessible formats. So all of those kind of start to create problems in terms of inclusion. And, these are barriers that have been found in the context of healthcare provision to erode trust, because patients with disabilities who come to a clinician and do not have accessible information for them, they cannot feel that they can trust the clinician and the healthcare system. And again, they feel inferior. It comes down to all of the 4 criteria for distrust. We also found harm-related concerns that participants in our study raised, with 42% worrying that precision medicine research might harm people like them, with 40% of them actually feeling that researchers and clinicians don't know their needs, so they won't be actually able to do much for them. And then you can see others concerns about stereotypes, as well as that precision medicine research won't help people like them. Other trust-related issues that came up, and our survey was kind of mostly closed questions, but we had very few open-ended questions. And I'll say we got about 500 responses in open-ended questions, which is a lot. But some of the things that we found as sort of things that came up a few times are, one, concerns about discrimination. As the statement from one participant here was, government organization agencies who offer services may misinterpret and or misuse the information from the research to complicate or deny potential accommodations. Again, worrying that their data will be misused in order to prevent them from having accommodations that they need. Another kind of concern that came up a few times is concern about individual harms and the fact that researchers might not understand the perspectives of people with disabilities. Here, participants stated, I would be more likely to participate in precision medicine research if the researchers had an understanding of the social model of disability and understood that many disabled people with non-painful disabilities aren't interested in cure. And then there were quite a bunch of comments about concerns about group harm and social justice. Again, this is kind of one of the nicest quotes that we got, but it's parts of precision medicine research may be useful, but it sounds too cripply eugenics supporting. If the researchers had extensive knowledge and experience in disability, social justice history and issues, and were disabled themselves, it would be better. So that kind of feels, we don't really know if all of those things apply to all people with disabilities. We don't know if there's differences between those who had more contested relationship with a medical profession or less. That these are things, again, that we're exploring now, but we do know that 76% of our population, of our participants, had between 3 to 8 access, communication, and other barriers to participation in precision medicine research. And in fact, even though we kept saying, our study, the precision medicine research aims to enroll people with diverse background, everyone is welcome, blah, 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 we got the statement, well, the precision medicine researchers won't want to include people with disabilities. And if you think about it, if you have 3 to 8 barriers to participate, you really have to really, really want it in order to participate, because you've got to cross so many barriers to do so. So that brings me to the last part here that I wanted us to discuss. And, when we're thinking about precision medicine research, again, if it is aimed to develop a new healthcare system, to increase the knowledge for chronic diseases, we really have to have that diversity. But what we currently have is we have a very separate and unequal systems for research that involves people with disabilities. On the one hand, we have most people with disabilities who are enrolled into studies will be enrolled into disability-specific studies, most of which will be focusing only on the genetics of their particular condition, whether it's autism, whether it's psychiatric conditions, whether it's being deaf, the focus, or blind. The focus is really on how do we identify the genetic underpinning for their condition, but it doesn't look at them as whole people. It doesn't look at the environments that impact it. It doesn't look at the lifestyle choices. It doesn't look at chronic conditions, which are much more impactful in these communities. And so it's really problematic. And if you look at the graph on the right, it's kind of indicative of that, right? This is from a federal agency that supports genomic research, that supports research into autism. And ultimately, it comes down to it that about 85% of the annual budget goes to looking into the genetic underpinning and prevention, with only 5% that actually goes to other things like um, to services for autistic individuals, and 2% go for lifespan issues. So the disparity is tremendous. It's not 50-50. It's like we're making here a very clear statement. Our goal is to eradicate certain populations, but we're not providing for those who exist. And at the same time, again, precision medicine research, if we think about all those barriers for inclusion in mainstream precision medicine research, we're kind of creating this double system, right? Again, one that's only disability focused, only genetic focus, only impairment focus. The ones that are for chronic diseases, health disparities, are not inclusive of people with disabilities. So that's obviously a significant challenge that we're going to have to think about. It also means that in our brains, we're kind of reinforcing the perception of people with disabilities is limited to their condition, to their impairment. We're continuing the idea of not thinking about them as full individuals that really are beyond their disability. Another major impact of that question of diversity is privacy risks. And of course, there's a lot of efforts to create systems that secure the data, that prevent hacking of the data, and so forth. But that dual system of research actually has significant implications for people with disabilities, because we know that the smaller the samples are, the smaller the cohorts are, the greater the risk are for re-identification. So we have here a system where, on the one hand, when you're looking into genetics, disability-specific cohorts, they're usually very small, especially as you go to the rare diseases conditions. Sometimes it's a cohort of 1, 2, 3 people. Their risk for re-identification is much higher. At the same time, in the general mainstream precision medicine research cohorts, because representation of people with disabilities is so small, they become at greater risk for re-identification as well. And that's especially when you combine it with other types of data, such as residential area, whether they live in rural or urban communities. Rural communities, you have higher risk for re-identification. All the more so if you bring with it the genomic data, which again, if some of them have those few conditions, then it adds to the risk of re-identification. So I think we really have to think about what are the protections in place ultimately to ensure that we're still protecting the privacy of those individuals. And the other thing that with precision medicine research is that we're increasingly kind of combining different data sets, right? We're combining data sets from the health research with data from employers, data from healthcare services, data from food stamps providers, and so forth. These other data sets have much higher prevalence of people with disabilities because of discrimination, because we know that they're not managing to get jobs. So these are all the things that kind of increase the risk, and we have not yet even begun to think about how do we protect subpopulations within the existing cohorts and ensure that they don't have greater risks of re-identification. And then finally, I want to mention data sharing. So the United States has not always had the policy of data sharing. But in January 2023, which is just last month, the NIH actually, a policy by the NIH entered into force requiring, or at least strongly encouraging researchers to share data that was collected in the realm of through NIH-funded studies. Now, of course, there are significant advantages for data sharing from the idea that we want to accelerate research. We want to create big data sets, and smaller data sets are just not as helpful. We want to create to save time and money by not duplicating existing research. And we want to create training opportunities for new researchers, for emerging researchers, and so forth, to enable them to use the data. So there's a lot of good things in the idea behind data sharing. And I think part of the NIH perspective is really that data sharing is a public good, right? You're paying for those studies with NIH money. That then the data that's collected through that process also has to be part of the public good. The problem in the United States is that we do not have a right to healthcare, and we don't have a right to the benefit to benefit sharing the way it might be in other European and Scandinavian countries. So I think when we think about it in that context, we also have to think about the downstream implications of data sharing, especially for the very communities that are invested or engaged in this type of processes. And I want to mention here two things. One is that, again, we have data sharing, but we don't have benefit sharing. And we have data sharing that could essentially provide access to the data to anyone who is doing research, including secondary users who have themselves contributed to the health disparities of the populations. And one of the examples that came up in our study was, for example, among blind participants. So as I mentioned, they were the first ones to be invested in. We want to be part of precision medicine research. We want to participate. We want to give our data. We want to get results. However, when we asked them questions about who are you willing to share your data with, it crashed completely when it went to drug companies. They were willing to share the data with NIH. They were willing to share their data with researchers at American universities, not with others. And part of the argument was, hey, drug companies have for years created medications that are inaccessible for us. It doesn't have Braille, it doesn't have accessible formats. Because of them, we cannot take care of ourselves, but they want our data. We do not want to have that. And again, we're hearing it from other communities as well. So I think that's something that we're going to see more and more in the future. The second challenge that I wanted to highlight is the dignitary harms by secondary users. And that's something we don't tend to think about so much. We think about eugenics as the practical aspect of it, but the language that we use and researchers use to describe specific communities has impact on how we conceptualize those communities. So again, the deaf community is one of them. The autistic community is another one. But the whole conversation, do we describe people as incapable, or do we think about them as able? And the way even if I'm as a regional researcher can work with my community, and actually we work very closely with them to make sure that the language we use in our articles is respectful of their preferences. When it comes to secondary users and data sharing, I lose control over that data, and therefore I can no longer control or ensure that secondary users will use the same respect that I can use in my studies. So this is something that's been coming up again and again, and I think we have to start thinking about it. How do we create a system where, yes, data sharing is great, but it has to come, one, with benefit sharing, and two, it has to come with responsibility sharing to ensure also that secondary users are actually doing research that's respectful of the community, and that dissemination practices are also respectful of that community and do not reinforce existing biases, stigma, and ableism in our context. So just a few quick words about moving forward. So again, I think there are systemic issues that increase distrust among people with disabilities in precision medicine research and are likely to exclude them from mainstream precision medicine research. And I think we have to really start thinking about how do we move to create a disability ethics in precision medicine research, one that focuses on data collection. At the moment, we do not collect data about disability status. We collect data about gender, race, ethnicity, residence, income, education. We do not collect data about people with disabilities. Have a question. That's one thing to kind of know what's the diversity of our communities. We also have to think more about community engagement. Again, in a study that we've started doing, we find that there is very, very little community engagement studies with people with disabilities. If we do have them, they're very local, very specific with subpopulations. We have to revisit the mispresumptions that we currently have and try to think, are these presumptions real, or is it that we create inaccessible processes? And just think even about consent forms, right? In so many institutional review boards, blind people have to bring a witness to sign a consent form to participate in a study. And they say to me correctly, why the hell would we do it? We're independent individuals. Why do we need to do such a thing when in fact, if you just sent it to me in an accessible format, I can sign it myself, right? But we're not creating those processes in place at this point that would allow inclusion with empowerment the way we envisioned for the rest of the population. And then again, thinking about disability-tailored approaches, how do we create systems and programs and precision medicine studies that are more accessible? Most of the studies today are being done quite significantly online, and yet we still think about accessibility just as the ramp. We have to create online systems that are accessible for folks with disabilities and diverse abilities. We have to think about how do we use the language when we invite them to come into those studies so they don't feel that they're being inferior or mistreated. And we have to really engage with them. So these are kind of the hopes I have for the future. And I think part of our study is trying to, at the moment, to figure out more specific steps that can be done to create more trustworthy precision medicine research programs. We're also working on developing another study that will create a tailored consent form. So researchers can use it. It will be both accessible for people with disabilities and be tailored to the needs of researchers, trying to have, again, more bridges here on the way. But this is a process, and I think we have to start thinking broader. How do we actually ensure inclusion beyond the usual categories? They're important. But again, if you think about the prevalence of disability also within these communities, we're not going to be able to achieve anything if we're not moving forward with those issues as well. So just to say a lot of thank you to all my research participants, community partners, advisory board members, my funders, and of course the research team that has been helpful in working with me on different aspects of this presentation. So thank you, and I'm happy to take questions.